I'll give a background, but to orient everyone, a little primer in immunology and the background on the problem that we're trying to solve at Q Biologics. Some of you may be familiar with this concept. This was published in the New England Journal of Medicine prior to the COVID-19 pandemic, so some of the figures may look a little bit different, but we made a lot of strides in reducing the burden of infectious diseases, and infectious diseases was a major cause of morbidity and mortality previously. And what has occurred is with the improved hygiene, therapeutics such as antibiotics and vaccines, improved socioeconomic status, as well as improved nutrition have all led to infectious diseases taking a back burner to some of the other diseases that have risen in parallel. And many of these are immune-related diseases. And this is the concept around this. It's simplified and colloquially called the hygiene hypothesis. And in that our immune systems are not educated or trained appropriately and thus more susceptible to the development of some of these immune-related diseases, as well as cancer. I would throw that into that bucket. And the diseases we're dealing with now are considered complex diseases. That means they're multifactorial. This diagram is a systems network approach looking at all the factors, and we're looking at Crohn's disease and ulcerative colitis, and you can see there are multiple targets that are affected in these two diseases. And the way we've been approaching their treatment is really looking now, with the advent of biologics, we're looking at single target approaches, and most of these are focused on suppressing the symptoms of the disease. So they haven't really, despite the arsenal of immunosuppressive medication we have available, they haven't really changed the trajectory of disease progression for the majority of patients suffering from either one of these diseases. So there is still a need for an appropriate treatment regimen for people living with inflammatory bowel diseases. At Q, what we realize is the common theme in many of these complex diseases, immune-related diseases, as well as cancer, is the role of the innate immune system, which is dysregulated in the vast majority of these immune-related diseases. Now, the innate immune system, as far as immunotherapeutic target goes, it is not as well focused on, I would say, from an immunotherapy perspective, relative to the adaptive immune system. And that's primarily because of its more esoteric nature. It has multiple ligands, multiple cells, as opposed to the B cells and T cells of the adaptive immune system, which is easier to grasp in terms of how they function. The innate immune system is a bit more of a handful. But we know it's essential. So if you didn't have an innate immune system, you wouldn't do, this is the graph on the left is pretty much demonstrating that you wouldn't do very well without an innate immune system. But you could do okay without an adaptive immune system. In fact, many organisms don't have an adaptive immune system, such as plants. And the concept of immunological memory was always in the bucket of the adaptive immune system. So we had always considered that if you want immune memory, then we're going to be targets such as the vaccines, they target adaptive immune function. And the type of memory that's encoded by the adaptive immune system is like a lock and key. The antigen recognition is very specific and it's non-transferable. Whereas the innate immune system was always considered to be immunologically void of memory. And what we've learned over the last, I would say just over a decade, the field of immunological memory of the innate arm has just become appreciated, and it's called trained innate immunity. And this was really the work of Mihai Innately, who studied kids who had been inoculated with the BCG vaccine. And he found that those kids who were inoculated with this live attenuated vaccine actually had better outcomes, health outcomes, than would be predicted by the target of the vaccine, which was tuberculosis. And what he discovered was that the innate immune function of these kids were significantly more competent and efficient in dealing with immune stress or immunological challenge. And so that type of memory is encoded at the epigenetic and metabolic wiring of the cells. And it's very similar, I think, in nature to muscle memory and neuronal memory, where you're challenged with a certain stimuli. When you get re-challenged and exposed to the same kind of stimulus, your ability to respond is a lot more better. It's a lot more efficient, essentially. So that's what trained innate immunity encompasses. And what we're doing at Q is we've discovered a way to train the innate immune system and also target it to where disease is present in the body. And we do this, we're basically exploiting a mechanism that has evolved in our body in that we select microbes that are endogenous and a common source of disease in a particular organ site. For example, Klebsiella species is ubiquitous in the human lung, Staph aureus for the skin, and E. coli is common in everyone's GI tract and proximal organs. And so we formulate our what we call site-specific immunomodulators from microbes that are endogenous and a common source of disease. And just to demonstrate what we mean by site-specific immunomodulators, here I'm showing you the 3 SSIs we currently have in clinical development. One is targeting the lung, the middle is the GI tract, and the one on the far corner is the skin. And I'm showing you 2 different models of in either cancer or infection at the bottom. And only the SSI that is made from the microbe that is endogenous in the diseased organ is effective in ameliorating disease in that targeted organ. And so this is despite the fact that the SSI is administered the same way by everyone. In fact, patients themselves are taught to self-administer, very similar to an insulin injection. And so despite that, we are able to get the immune system to target the organ where that bug is endogenous. So we published the mechanism. It's a hairy diagram and quite heavy in immunology, but the main, just if I was to summarize it, there are 6 steps. And we need to inject it because if you take it orally or intranasally, obviously your mucosa is full with different microbes, so it's not perceived as a threat. But when you're injecting it, you have bypassed multiple barriers, essentially. So it's perceived as an immunological threat. And this induces what we call myelopoiesis, emergency myelopoiesis in the bone marrow. And the new immune cells that are generated in the bone marrow in response to this perceived threat are functionally different. They're trained. They're more effective in dealing with challenges. And at the same time, your body, your immune system has to figure out where is this leak likely coming from, and it will target the site in the body where that bug is most highly concentrated because it can't send that army everywhere that would dilute the response. So in this case, we're showing the lung, and the end effector functions is dependent on whatever pathology is present. So the innate immune system is agnostic as to what the problem is. It will clear whatever is wrong, whether you have barrier dysfunction, whether you have cancer present, or whether you have infection. So it has broad applicability. And here I'm just showing you the indications, chronic inflammatory disorders, infection, and cancer. And the orange highlighted indications are those we've already published, demonstrated our proof of concept in. So I'll share with you now our story for inflammatory bowel disease, and we've gone into phase 2 trials. Now I'll have to start starting with IBD because a lot of people were confused as to why we think activating the immune system for a chronic inflammatory disorder is a good idea. It's like throwing fire on fire, essentially. And that was the response we had gotten from many doctors who are used to treating IBD using immune suppressive medication. But we did a randomized placebo-controlled trial. This is the first one we conducted. And we've published the results of the study. The primary outcome was 8 weeks. And we were looking at the reduction in the Crohn's disease activity index right here. And you can see a nice separation at 8 weeks between the green and QB echo-treated groups versus placebo. but we noticed that patients continued to respond for over 16 weeks. The way the trial was designed was really to help people be motivated to participate, because nobody wants to be in a trial where, and you have moderate to severe Crohn's disease and you won't be on treatment for very long. So the way the trial was designed is that whatever treatment, we'd first randomize either placebo or Kibiaco treatment for the first 8 weeks. And whatever blinded treatment subjects were randomized to, if they responded, they stayed on that treatment blinded for another 8 weeks. And if they were not responding to whatever treatment they were randomized to, they were put on open label Kibiaco. So everyone was guaranteed to have potentially a treatment that could potentially deal with their disease. So what we're showing here is those people who were responders to Kibiaco and stayed blinded on treatment, they continue to actually see a response over the next 8 weeks, so to week 16. However, those people who had initially responded to placebo, who had initially responded to placebo, they started to lose their treatment. I should mention that IBD of the placebo effect is at least 30-ish%, so it's fairly high. But it didn't remain consistent for the following 8 weeks, whereas everyone who was put on open label, if they weren't responding to the treatment, continued to respond to Kibiaco. So given that promising study, we did a follow-up study, a smaller phase 2 study, to understand what was happening immunologically and molecularly in these patients who were treated with Kibiaco. And so we went back and see, were their innate immune system being trained? And essentially this figure is showing you yes. And the way we measure trained innate immunity, we basically take blood cells, immune cells from patients at baseline, and then after we've treated them for 8 or 16 weeks, we look at their immune response if it's enhanced. And IL-1 beta is a prototypical marker of innate immune function. You can see it's significantly enhanced in subjects treated with Kibiaco. And GM-CSF is what induces the myelopoiesis response, and that was also enhanced. And what was really interesting is that the ability to train their innate immune system was correlated strongly with their clinical response to treatment. We'd also done, in the second study, we had taken biopsies and subjected to RNA-seq analysis at multiple sections of the colon. And the question we were asking is, we had multiple questions we were asking, one of which was, what are the signaling pathways that are changed in people who respond histologically to Kibiaco treatment? And here what I'm showing you is that the markers of inflammation, cytokine signaling, was really high at baseline. And these are all these, as I mentioned, complex diseases involve multiple factors. So there are multiple genes associated with cytokine-mediated signaling. But what we see was over the 26 weeks, you see a nice decline in all of these factors together. Same thing with immune cell infiltration or cell migration into the colon. It was really high at baseline, and then over 26 weeks of treatment, you saw a nice decline there as well. And neutrophil-mediated immunity. So neutrophil destruction is one of the main contributors to the gastrointestinal damage in patients with Crohn's disease. And we saw this was high at baseline in patients with severe disease, and it again declined over the 26 weeks of treatment. So the question is, how is this happening? You're adding something that activates the immune system, trains it, you're inducing higher levels of immune responses, and you're getting a decline here. So this goes back to the etiology of the disease. So in Crohn's disease, here I'm showing you a healthy gut. You have this nice microbial distance, a mucus layer that keeps the aluminum microbes on one side, the host epithelia, and it's all in homeostasis, and you don't have encroachment and infection of the gut. Whereas in patients with Crohn's disease, you see a reduction of this barrier and encroachment, and basically they have a leaky gut, so bugs get through. And so those inflammatory neutrophils and inflammatory T cells are just coming in to do their job because these patients have chronic infection of their gut. And in doing so, you get this collateral damage, if you will, in response to the immune response against the microbes. So what we've previously published is that we rebuild that barrier function such that you don't get a leaky gut and these encroachment of the inflammation. And by doing so, you don't have recruitment and inflammation taking place in the GI tract. So from that angle where we're treating a disease with overactive immune function happening, I'll then share with you the story in the context of cancer, which is in perspective of immunotherapies, it's on the other end of the spectrum because most of the biologics used to treat IBD try to suppress the immune function, whereas those treating cancer are trying to activate the immune system. And for solid tumors, there are three major challenges that we're facing. One is that there's a very strong immunosuppression in the tumor microenvironment. Secondly, the cells are unable to recognize malignant cells because most cancer cells have developed strategies to avoid immune recognition. And thirdly, there's an inability, or it's a challenge to get infiltration of activated immune cells into the tumor microenvironment where the solid tumor exists. We've had better luck with hematologic malignancies, especially with CAR T cells and other adoptive cell therapies, but we haven't been as successful with solid tumors, which make up the vast majority of cancers. So here I'm showing you, this is a lung cancer model, and we're treating with our lung-directed SSI QBKPN. And what I'm showing you is a significant increase in activated macrophages, M1 cells, as well as natural killer cells. And this was predicted by the mechanism of action I had previously shown. But what is really cool is that we actually make the cancer cell more visible with SSI treatment. So we upregulate stress-induced molecules on the cancer cells themselves, and we've published this as well. And it's dependent on the NKG2D pathway. And that pathway, if we use animals that don't have an active NKG2D receptor, we actually lose efficacy for cancer. And of course, this makes it amenable to other types of immunotherapies in use. And this is a collaboration we did with Dartmouth University, showing their different CAR T cell and adoptive T cell constructs. And this figure is essentially showing when you use an SSI together with the CAR T cell, you have the best efficacy in reducing the solid tumor. And this is looking at lung cancer model and an ovarian cancer model. So we really see good synergy with other adoptive cell therapies with this approach. We then went on to do a small study in collaboration with BC Cancer in patients with non-small cell lung cancer. And we were really looking at safety and as well as if we're able to reduce the immune suppression that was present. And in those patients, and this is over 12 weeks, in those patients with very high levels of inhibitory markers, so you may be familiar with PD-L1 and PD-1. These are inhibitory receptors that prevent cell killing or lysis of the cancer cell. We bring it back down to normal. We've been fortunate to get significant clinical experience through a compassionate use program, and this is in collaboration with a clinic in Austria. And so we've treated over 250 patients with advanced cancers. In Austria, you're able to, they have clinics that if you have not responded to conventional treatment, you have the option to try experimental treatments, and this clinic offers those options to patients. And the graph here on the left is essentially showing the outcome. This is a retrospective analysis of women with advanced breast cancer who were treated with SSIs and those who weren't treated with SSIs in the same clinic, and those who were had a 20-month median survival advantage. Given the promising results here, we were able to, independent researchers actually did a case match study looking at all comers, all different cancers at that clinic, and matched based on critical parameters such as stage of cancer, age, and gender. And we had 43 matched, case-matched participants who had been treated with SSIs and those who didn't. And we saw, again, a 12 months median survival advantage in these patients. And we were able to collect significant safety data, and it looked very good, very similar to traditional vaccines. So the data to date does show that this approach, the SSI approach, has the potential to overcome some of the major challenges of cancer immunotherapy, particularly for solid tumors. And now I'll use the remaining time to briefly give you some background on the current clinical trials that we have ongoing. So we have one, both of them are very unique in terms of trials, and I'm really excited about them. The first one is in collaboration with surgical oncologists mostly in Ontario, but we hope to open clinical trial sites across Canada. And it is looking at the ability to prevent post-surgical immune paralysis that leads to metastases in patients. So what I had no idea before until I had listened to Dr. Rebecca Auer. She's at the University of Ottawa. I had no idea that going in for surgery for removal of cancer actually induces a significant stress on the body, such that the immune system's response to any kind of challenge is pretty much paralyzed up to 7 days after the surgery. And the consequence of this, if you've gone in to remove cancer, is you can have any residual cancer cells remaining that have now no surveillance in place and an ability to micrometastasize. And so after listening to her presentation, I started a collaboration with her. I said, well, what if we treat perioperatively with the SSIs before and after surgery to see if we can prevent this immune suppression? And what she found, she had developed multiple models in her lab, and now we've done 3 different models of different cancers and surgery, showing that we can not only prevent that immune paralysis from taking place, but we can significantly reduce the metastasis that occurs as a consequence of this. So the trial we're doing is looking at late-stage colon cancer for patients who have liver metastases, and these patients typically have to go in to have a resection of their liver. And we'll be treating them. It's again a randomized placebo-controlled trial with 115 patients, and the primary outcome is 2-year progression-free survival. But we have a number of really interesting secondary and exploratory outcomes, looking at cell-free tumor DNA in circulation, how fast we can clear that after surgery, looking at the tumor microenvironment and immune function following surgery, and of course safety, and then the 5-year overall survival. So this is a really unique trial. I think there's no other intervention currently in place to address this need. And the second trial we are currently doing, and this is mostly in BC, it was really born out of our experience with COVID-19. So of course, everyone now knows that the elderly were the most affected by the pandemic. And one of the reasons why is their innate immune function declines with age. And we had, prior to the pandemic, actually done with McMaster, this is probably 7 years ago, we had done a study looking at different types of respiratory infections, and we had both young animals and elderly animals. And young animals cleared the infection quite well. There was no difference with treatment. But in the elderly animals that were treated with the SSI, they actually prevented mortality from respiratory infections. And then this was a bacterial infection. We didn't test it, we didn't have time at that time. In aged animals, but we've shown that we can also reduce viral load in the lungs using QBKPN. And this spurred our current clinical trial in the elderly. So we're asking the question, can we train the innate immune system in the lungs of elderly individuals? And we'll be looking at, the primary outcome is actually looking at innate immune training. That would be a massive win if we can show that we can improve lung innate immune function in people who are older. So it's called the Resilience trial, and we Ted Steiner, I don't know if anyone, he's from UBC, he's the head of infectious diseases. He's the lead investigator of that study. Again, we'll be looking at 72 participants who are either randomized to receive QBKPN or placebo. And we'll also be looking at overall clinical outcomes such as respiratory infections, morbidity, and mortality. So with that, I'd like to thank, if you want to know anything more about the trials, you can go to our website and you can get more information from there if you're interested in learning more about that. This is, of course, it takes a village to bring a drug to the clinic, and I'd like to thank and acknowledge our industry partners as well as our academic partners. And I'll leave you with our fearless team here at Q Biologics. Thank you so much for the attention and the opportunity to speak to you.